task force members consist of OCAPICA, Korean Community Services, Asian American Senior Citizen Service Center, Hope Community Services, Pacific Islander Health Partnership, South Asian Network, Southland Integrated Services, the Community Family, the Rainbow of Orange County, and also us. We're here because for the most part, COVID-19 had made major impacts to different communities in different ways. And there have been a particular concern for the communities of color and low socioeconomics like ours. So we're bringing together a whole spectrum of outreach, education, and also navigation to screening and patient care in that respect. So thank you so much for being here, and thank you to Dr. Huang Lei and Dr. Marvin Reyes for being our champion of COVID-19. So we're here to listen to you, and we're hoping that we could learn more and educate our communities a little more. So thank you so much for being here, and thank you to the doctors for spending your afternoon with us. We appreciate it very much. The screen is yours, Dr. Huang.
Okay, I'll thank you, Becky. I'll take on behalf of Dr. Marvin Reyes and I. We are very flattered to have been asked to help API with this task. And just before we start, we all know COVID, whatever involves COVID-19 is a very fluid situation. Things change pretty much on a daily basis. So whatever we're talking about today may be different tomorrow or maybe later on this evening, depending on, who would say something. So just really know what we're talking about, and things may change. And again, thank you for giving us this opportunity. We're clinicians. Dr. Marvin Reyes is infectious disease. I am pulmonary critical care. And, fortunately or unfortunately, our specialties have been quite busy with the whole pandemic. And, we've seen a decent number of patients here in Orange County. So we'll stop there in terms of my conversation. I will hand the mic over to Dr. Marvin Reyes to have a few words with you and you guys, and then he'll start the presentation. And again, thank you, thanks to all of you to help our community here, not just for COVID, but with everything else. And I think that whatever you do does not go unnoticed. So we, from a clinician standpoint, and just from a community member of Orange County, we appreciate what you do. Go ahead, Dr. Reyes.
Thank you, Dr. Lei. I just would also like to say thank you to everybody for inviting me and Dr. Lei to speak at this virtual event. I think we all appreciate how important this issue is, and in particular, educating the community and the public about COVID, and certainly the service that everybody provides to our respective communities is very much appreciated. So we will go ahead and get started on the slideshow. Okay, thank you. So
but just tell me when you want me to go to the next slide, okay?
Okay, thanks. Yeah. So yeah, coronavirus is, really, it's hard to imagine now in 2020, since, COVID has really taken over all our lives. But, 20 years ago, coronaviruses was kind of just had a small role in medical education and what we knew about infectious disease. I remember, studying for the medical boards when I was in medical school, and, there was like maybe 2 sentences or not even a paragraph about coronaviruses, because again, before 2002, the only thing we knew about coronaviruses was that it caused, basically the common cold, a pretty innocuous virus for the most part. But then I think we probably all remember in 2002, we started hearing about this severe respiratory syndrome that was affecting some, previously healthy people in in Southeast China and then Hong Kong. This later became known as SARS, or severe acute respiratory syndrome. Subsequently, it was later determined that this was from a novel coronavirus that was felt that it was originated from bats with an intermediate host, probably from animals that were sold in the wet markets, and then it proceeded to cause pretty significant disease in a lot of different countries. Fortunately, it died down a little bit. It did significant damage for about a year or 2 years, but for the most part, the world, the global health community was able to contain that pandemic. And then about 10 years later, we also probably remember a similar type of syndrome affecting people that started in Saudi Arabia and also other parts of the Arabian Peninsula, and this was later became known as MERS, which was also determined to be a related coronavirus. And then I think late 2019 we started hearing about this, again, similar type of clinical syndrome, also again starting in China. And then, fast forward 9 months later, it's gone on to affect, most of the countries in the world, over 1 million deaths globally, and over 200,000 deaths in the US alone. And like I said, it started to sort of overtake our lives in most of 2020. Next slide, please. So the meat of, I guess, what this talk is supposed to go over is some of the testing that we will I think you guys are all providing to some of our community members. So testing basics, it's basically can be divided up into 2 big categories. I'm going to start with the right side of this slide. So I think when we think about tests for COVID, most of us think about the right side of the slide, which is diagnostic tests to indicate if somebody has COVID-19 at that given moment. And there's 2 categories of diagnostic tests. One, and that's the most common one, and I think that's also the default that we all think about, and that's the molecular or PCR tests. This is also otherwise known as, you might hear things like NAAT, or nucleic acid amplification tests as well, or reverse transcriptase PCR tests. They all sort of kind of refer to the same thing, and that's a test that will detect the genetic material of the virus of COVID-19 in a given respiratory sample, usually upper respiratory sample. This is, again, the test that most of us think about when we talk about a diagnostic test, and this is probably the preferred. This is indeed the preferred test for diagnosis. There's a second type of diagnostic test, and that's called the antigen test. So whereas the first test detects the genetic material, the antigen test detects proteins that are present on the surface of the virus. In general, antigen tests, are what we call a little bit less sensitive than PCR tests, and the reason for that is these tests cannot detect virus at lower levels. Whereas PCR tests, they can, even very, very minuscule amounts of virus genetic material can be amplified and detected. So in general, one rule of thumb is the more sensitive or accurate tests are the molecular or PCR tests. And I think in the next slide, we're going to discuss a little bit more about sensitivity and specificity regarding testing. But in general, just one rule of thumb is the molecular PCR tests are the most accurate, and we'll go into more specifics about what that means. And on the left side of the slide, That's the second category of testing, which alludes to screening tests or antibody/serology tests. So these are tests as opposed to the other diagnostic test, which is obtained from a respiratory sample usually. This is from a blood sample. So looking at the patient's serum for evidence of the antibodies that's produced by the immune system as a response to the virus. Antibodies are proteins that the immune system helps to form as a response to a given infection. And this process takes a while, right? So as opposed to the other tests where if the virus is there in somebody's upper airway, then a test will detect it right at that moment that it's there, and it will say that the patient is positive. This test takes anywhere between 1 week to about 3 weeks to turn positive. So the immune system needs that time to develop these antibodies. Therefore, in the beginning, when somebody might still be symptomatic from the infection, these tests often, if it was ordered for somebody, oftentimes these tests will be negative. So again, this is not useful to diagnose an active or acute infection, but it's more helpful, for example, in somebody that's maybe been sick for like 2-3 weeks, and maybe they did not get a diagnostic test initially, but they're coming into the hospital or the clinic and telling the clinician, I've been having these symptoms for 3 weeks, and this might be one of those, this might be a test to use in that scenario, after somebody's been a few weeks into somebody's illness. Next slide, please. So, in addition to those kind of big categories of tests, there's additional tests that we may hear about on the left side of the slide, and some of these are what we call rapid or point of care diagnostic test, point of care, because you get the results right there at the urgent care or the doctor's office. And again, most of these are also antigen tests. I think for the most part, most of these are actually antigen tests. There's some rapid tests that are available that some hospitals have that are molecular or PCR tests also. But basically, when we refer to a rapid point of care test, it's just a test with a result that you get within a few minutes usually. And then there's also, we've heard of at-home collection tests, and I don't believe this is really quite available yet, but these are kits that the patient goes home with, and then they collect usually either an anterior nary swab or a throat swab, and sometimes a saliva test, and then they send it in and they get the results after a few days. And on the right side is again those terms that we talked about a little bit, sensitivity and specificity. So these are basically performance measures of a test that will tell us how accurate a given test is. So sensitivity refers to the proportion of people with that disease, so COVID-19, proportion of people with COVID-19 who will end up testing positive. So if we say a test has, let's say, 95% sensitivity, that means that out of 100 people that come in to get tested with COVID, so these 100 people all have COVID-19, 95 will test positive from that test, and 5% will be what we call false negatives, or basically they will test negative falsely from that test. So we know they have it, yet they test negative. So a test that gives us 95% sensitivity, that's what that means. Basically 5% false negatives. And then the specificity refers to the proportion of people without COVID-19 who end up testing negative. So it's like the converse of sensitivity. So again, similar example. If 100 people without COVID-19 come in to get tested, and let's say a test has 99% specificity, what that means is out of those 100 people that do not have COVID, 99% will have a negative test, and 1 will show a positive test even though they do not have the disease. So 1%, so 99% specificity equals 1% false positive rate. So obviously in tests, in diagnostic tests, we want tests that have offer high sensitivity and high specificity for obvious reasons. And I think we'll touch on some of the performance characteristics of some of these tests in subsequent slides. Next slide, please. All right, so the next, I think, 2 slides will run through some of the characteristics of each of the 3 categories of test modalities that we generally use. So on the first leftmost column is, again, the molecular or PCR tests. So it lists some of the other names that we could use to refer to this test, but I think PCR test is what people mostly refer to. But again, viral test, molecular test, nucleic acid amplification test, NAAT, reverse transcriptase PCR test, those are all terms that can be used to refer to this. And like we alluded to, basically the test, the machine amplifies, even a minuscule amount of viral DNA or RNA. In COVID-19's case, it's an RNA, and it amplifies that small amount, and then the machine detects it, and then it will give an answer positive or negative. As of now, all we have in terms of tests, the only results we can get are qualitative tests, so positive or negative. None of the tests, I believe, have been validated to give quantitative results too. I mean, meaning how much virus there really is in a sample. So all you get is a positive or negative. Most of the molecular tests are collected from the upper airway. So nasopharyngeal, so a deep collection, Q-tip about 3 inches into the nostril and up all the way up until you reach the pharynx, basically. It's also some tests will use a throat swab or a pharyngeal, and then some tests are validated to use just an anterior nares swab, so not all the way deep down, but just kind of slightly inserted. The Q-tip is slightly inserted in. And then there's also some tests that are validated to use saliva tests. There's varying sensitivities based on the different collection, based on different samples. And then there's also varying sensitivities based on the type of test that is used. And that sensitivity for most of these molecular tests is quite variable, but for the most part, most of these tests are anywhere between 80 to 95% sensitive. So again, at best, you can get like about anywhere between 3 to 5% false negative. So that's still an important thing to remember. How long did the test take? And again, some of the machines can give you a result within a few minutes or a few hours, but those are mostly available in emergency room settings. But the other ones that you get from other laboratories, Quest and CVS, I think the time, at least in Orange County, I was told it's still about 3 or 4 days sometimes. And again, what does it show? It indicates active coronavirus infection. What can it not do? It generally cannot detect past coronavirus infection. However, there is one caveat to that I want to say. These molecular tests, they can still persistently be positive weeks, if not months, after somebody has recovered from COVID. So sometimes it's not an uncommon scenario that Dr. Lay and I will see that somebody had COVID, a month ago. They recovered, they went home, they get readmitted to the hospital because of maybe something unrelated. And, the ER will do the molecular swab again, even when they're not symptomatic from COVID. And sometimes the test will still come back positive. So, and we've learned now that basically what that indicates is just, remnants of the previous infection, remnants of the, some of the non-viable viral remnants that remain in the nasopharynx or the airway that the PCR test picks up. So the molecular test cannot distinguish live versus non-viable virus particles. Do you need another test if you get a negative molecular PCR test? So in general, you don't. But again, remember the caveat that I said a few minutes ago. These tests, again, at best are maybe 98% sensitive. So that what that means is maybe anywhere between 2 to 5 to sometimes 20% false negative, depending on the type of test. So even though we consider it fairly accurate, and it's probably the best of all the tests that we have in diagnosing acute COVID, it's not 100%. So also in some situations that Dr. Lay and I have seen where somebody comes in with all the signs and symptoms, the x-ray looks like COVID, they're behaving like COVID, and we get a negative test, oftentimes we will repeat it. And most of the time the second test or the third test will be positive. On the second column is the antigen test. So again, detecting the proteins on the surface of the virus. Again, a little bit less sensitive than the molecular test. So these are usually rapid tests too. And most of the point of care or kits that doctors' offices and urgent cares have will be this type of test. Again, it detects the viral proteins as opposed to the genomic material. They're usually a nasopharyngeal or nasal swab as well. Rapid test results, it detects active coronavirus infection similar to the molecular test. What it cannot do, similar to the molecular test, it cannot detect past coronavirus infection. And importantly, they're generally less sensitive, therefore provides higher rates of false negatives than the molecular test. So if a patient is tested and they have a negative antigen test, oftentimes we will want to get, especially if there's reasonable clinical suspicion, oftentimes we will still have them do a molecular test to confirm that negative result. And I think that the last row on that middle column, again, talks about that. Positive tests are highly accurate. So yeah, if somebody tests positive on antigen test, that's it, you're done. They have it. But negative tests, especially if the suspicion is high, we oftentimes will get a confirmatory molecular test. The last column on the right, antibody test, again, that's the blood test that detects not acute or current infection, but recovering patients or previous infection. And so this is blood tests. And again, it detects antibodies to the viral proteins. These are blood draws, so not a nasal swab, nothing collected from the patient's airway, purely a blood draw. The results, I think, are about a few days. And again, it indicates past coronavirus infection. What it cannot do, again, it cannot detect somebody with active infection. Do you need another test? Oh, okay. Yeah. In general, people would like to confirm the test, perhaps a few weeks later with these serologies. Next slide, please. I think we may have skipped one. No? Okay, thanks. Yeah, so a little bit more characteristics of the tests. Back on the left, so when, for the molecular test, the patient most often, the time frame when the patient will have the highest level of virus is usually, around the day that they develop symptoms. So you start to shed virus about 2 days before you develop symptoms, up until about 5-7 days after your symptoms have developed. So the peak is probably around day 2 or 3 of somebody's symptoms in people that have symptoms. Again, some people have no symptoms or minimal symptoms, but in most people that have symptoms, the virus peak, the virus level peak, occurs about 2-3 days after symptoms have started. So the most reliable, the best sensitivity of the test is usually around that time, a few days after symptoms started. And then over time, after, as time goes by, then the level of virus declines, and then therefore the level of positivity of the test also declines. The false negative rates with the molecular virus, usually, if the patient is exposed today, if you send them for a test today, obviously most of the time, if not 100%, they're going to test negative because the virus has not had enough time to replicate in the nasopharynx. So the test will be negative. Even probably 2-3 days after exposure, before symptoms, if you send somebody for a test, then most of the time there's probably going to be negative. And then you start to see them be positive, about 2 days before their symptoms start, or about day 3 after exposure. And so sensitivity does depend on the sample type and the sample collection, and then also the time frame of when the test was collected. And on the bottom row are some of the names, some of the makers, and the names of the specific tests that are used, that are examples of a molecular test. Antigen test in the second row. We don't like to use it for people that have no symptoms, because people that are asymptomatic, even though they are carrying the virus, they tend to have lesser of a viral load, lesser levels of virus in the airways. Therefore, the antigen, and again, remember, the antigen test picks up smaller quantity is not able to pick up small quantities of the virus. Therefore, it's not the best test for asymptomatic people. Now, in certain situations where you can repeat, you have the luxury of repeating tests after a few days, like nursing homes or jails, where they can, do systematic, regular testing, then an antigen test, I think, is probably adequate, because even if you test somebody negative one day, if you repeat it after a few days, usually you'll pick that up. But in general, again, antigen tests are less sensitive. And on the last column, once again, you need at least 7 days, and usually about 3 weeks before antibodies are formed. So the serology tests, usually you don't want to do it before then. Specificity of the serology tests is unclear, because again, it's felt that there's probably some cross reactivity with some of the other non-COVID coronaviruses. So some of the circulating regular community coronaviruses can cross-react with the antibodies for that can cross-react to the test. Therefore, somebody that comes in with a positive antibody test doesn't necessarily, we can't say for sure that they had recovered from COVID-19. Next slide, please. So who should get tested? On the left side, obviously people with symptoms. And most of us are familiar with the symptoms. They're kind of upper respiratory infection symptoms. And again, the problem is it's hard to distinguish from other respiratory viruses like the flu. Something to remember is a lot of people will have gastrointestinal symptoms. Some people will have mainly gastrointestinal symptoms, if not only gastrointestinal symptoms, at least initially. So that's important to remember. And then also we do recommend testing for people without symptoms, who meet the listed public health criteria. So those are, again, people that work and live in skilled nursing facilities, jails, shelters, and then obviously people that have been exposed, especially healthcare workers or first responders, and then essential workers. Next slide, please. So the next few slides lists some of the sites for testing, and I think we might mostly be familiar with these. So a lot of people with health insurance will be able to go to their healthcare practitioners, and then there are some community safety net options for people that don't have medical insurance, and those are listed on the right. So I'm sure this is probably not an exhaustive list, but I think the reference for some of those lists are listed on the bottom of the slide. Next slide, please. And then there's also even more other sites possible for uninsured people, and I have met some people that have gotten tested at the Anaheim Convention Center, and they've told me that it's relatively seamless to do that. And then on the right, a few more sites listed. Again, I think the reference on the bottom for anybody that needs to refer any patients or potential patients, that's a useful website. Next slide, please. And then I think you guys are community members will frequently get asked, what do I do now if I, for example, have a family member who tested positive, and so there's a lot of overlap between these two, but quarantine and isolation. Quarantine, this is what we were doing a lot before, like in March, April, when we couldn't get tests for a lot of people, and again, these are people that had COVID or maybe had symptoms that could not get tested, and this is what we did. We did quarantine. So again, that refers to people who were in close contact with someone with COVID-19. And back then, before we couldn't test a lot of people, we told people to stay at home in your own room for 2 weeks, and the reason why 14 days is because some of the average incubation period is about 5 days, but it could be up to 14 days. So some people could theoretically get exposed today and be completely asymptomatic until 14 days out. Those are outliers. Most people, again, will start developing symptoms by 5 days. But but anyway, that's why 14 days was used, because you can develop. We were worried that somebody may develop symptoms after 14 days. But basically, after 14 days, if you haven't developed symptoms, then you're not going to. And for the most part, isolation is what we do now, because thankfully we do have tests that are pretty available, and so isolation is what we do for people that have tested positive, or at least people that are symptomatic that are awaiting test results. And so what we encourage them to do is to stay home, separate from their family members, starting from when ideally they have symptoms, or when they get notified of the test result. But ideally they were isolating before that. But basically we keep them in isolation. We tell them to stay in isolation for 10 days. So the start of the countdown is basically when the symptoms started for symptomatic patients. So you count 10 days after, and then if 10 days have elapsed and they're no longer having fever for at least a day, and preferably their symptoms are improving, but mainly it's 10 days. After 10 days, then they can safely come off isolation. And again, we know that because there's been some researchers that have tried to grow the virus in people in live culture, and that's when we know somebody is still contagious or shedding contagious virus. And they were not able to do that after about 8-9 days. So that's why we use 10 days, at least in most people that aren't that severely sick. And then if somebody is asymptomatic but tested positive, then we also say 10 days from the date of the test. And when isolation, just to be clear, a separate room ideally, open windows, and ideally a separate bathroom because there is potential of shedding virus in the stool. And okay, so all positive tests will be patients will be notified or reported to the healthcare agency, and then the healthcare agency will then do the contact tracing. And earlier in the pandemic, I think the health department was pretty overwhelmed. It sounds like maybe they're doing they're catching up a little bit with the decreased cases. But these are these are what maybe some of the community members will be asked on the left. And one thing to remember is that they will remain anonymous, so their contacts will not be told who potentially exposed them. And I think it's important on the right too that you can reassure the community members that they should not be asked for the social security number, immigration status, or any payment. They should not be required to give any payment information. So we can reassure, especially some of our community members that might not have a stable immigration status. No, this is not a reason to be afraid of the contact tracers. Next slide, please. And then we encourage the patient themselves to try anyway. For them to tell the contacts directly, even though, again, ideally the healthcare agency would do that. It would help everybody if they just took the initiative to notify contacts themselves. So close contacts are people that were within 6 feet of you for 15 or more minutes during your infectious period. And again, your infectious period, if you had COVID, is usually 2 days before your symptoms started until 10 days after symptoms started. And then again, for those that did not have symptoms, 2 days before your test through 10 days after your positive test.
Okay. I think that was your last slide, Dr. Reyes.
Yes, Dr. Lay.
Okay. All right. So, again, thanks, Dr. Reyes, for going through. That was actually the bulk, all the important stuff that he was kind enough to take on and leave me the much simpler part to talk to everyone from here on out. So anyway, so there's a few things that we're going to talk about. So this slide talks about vaccine, and we all hear about vaccine on the news pretty much every day now, and that is sort of like something that we're trying to reach for, because that may be one of the things that would really slow down or hopefully get rid of this significant disease. But unfortunately, vaccines take years of development, research, and testing. And as we all can hear that scientists, different companies are working very, very diligently, and hopefully they can produce a safe, that's the key word, safe COVID-19 vaccine by next year. So the vaccine testing process, and this is for all of the vaccines that come into the market, especially for the U.S., the approval level is a lot stricter than other countries. And you got the preclinical testing, it's very cellular level animal testing. We got phase 1 safety trial, and usually these are tests on the small number of folks for mainly what is the right dose of the vaccine, and also whether it's safe or not. And then, from there on, we'll go to phase 2, expanded trial, testing on a little bit more people, but hundreds of people in regards to the vaccine, and phase 3 efficacy trials. And that's what we hear a lot, right? Like in the news, like this company has phase 3, that company has a phase 3 trial. And this is when the vaccine is tested on thousands of people, and usually there are two arms, right? One group of people who had the placebo, not that the other group has a vaccine, and you're going to see whether the vaccine can mount a response in the folks tested with it, and also whether it's effective, and again, whether it's safe. And the approval process is, again, depending on the trial results. And right now, different companies have different vaccines. And you probably have heard recently that some countries approve vaccines without phase 3 trial. And, this could pose a lot of serious risk. And unfortunately, as we talk today, there is no approved vaccine yet for COVID-19. But then a lot of them are on phase 3 trial as we speak. So, this is definitely one of the hot topic that we all hear about in the press and unfortunately our politics. So we switch gear a little bit to treatment modalities. So, Dr. Reyes touched on symptoms, what kind of symptom the patient may exhibit, when, and how. And treatment modalities, unfortunately right now, again, just that we don't have a vaccine, we don't have a specific therapy that treats the actual, SARS-CoV-2, that coronavirus. We don't have a medication that specifically attacks that virus. So a lot of our treatment, whether the patient's at home or they unfortunately have to be hospitalized, is supportive care, okay? And supportive care is the majority of what we recommend patients. So let's say if I have a patient who tested positive and he or she feels horrible, they have fever, they have aches all over the body, they may have some gastrointestinal symptoms like Dr. Reyes mentioned. But the key thing, the few things that we recommend patients to go to the hospital, the first thing is whether they get short of breath, okay? If they're short of breath, we tell them you got to go to the hospital. Or a lot of patients, unfortunately, they have significant gastrointestinal symptoms that they become really dehydrated, and those other folks also will show up to the hospital. But when they go to the hospital, then the treatment modality is a little bit different. And some of the items on this particular slide that we use in the hospital. So I'm going to try to go through quickly, but in hopes that we're all aware of it. This is what is being done in the hospital more than anything else. So the first item here is called prone positioning. Prone positioning is when the patient goes in the hospital and usually they're short of breath. They may need oxygen. And when we ask them to do is actually, instead of sleeping on their back, we ask them if they can to sleep on their belly, to flip them over. So just to quickly, the way to look at it is most of the time you go in a hospital or you're sick, right? You're staying at home, we lay on our back. So when the lungs, the bottom part of the lungs, when we lay on our back, closer to our back, those are the lungs that are more affected just because of gravity, right? So when we prone the patient, when we flip them over, and sometimes we actually use a specialized bed to flip the patient over, which is trying to even out, the abnormal parts of the lungs, so that by using gravity, we want to kind of distribute the abnormal and the normal parts of the lungs so that oxygenation can help. So that's something that we do quite often in the hospital. And obviously, when they go in, they get short of breath. We provide the patient's oxygen supplementation, and that can go just a little, nasal cannula through their nose, or they need a little bit more. We use certain masks or certain devices that would provide pretty much the maximum amount of oxygen that the patient needs in order to maintain a certain amount of oxygenation level so that their organs can work well, circulation and everything. And unfortunately, a decent number of patients that we see, Dr. Reyes and I see, that no matter how much oxygen you give them, no matter what kind of, system you use, we just can't maintain their oxygenation. Then the next step is we have to go to the ventilators, which, we've all heard since March and April, we don't have ventilators. Who makes ventilators? Who sell ventilators? So ventilator, that's this machine that would help the patient. We have to connect them. Usually when the patients get into that condition, we have to put a small tube in the mouth, inside the windpipe, inside the trachea, and then we hook that up to a machine and the ventilator. And by using the ventilator, we can actually help the patient breathe a lot better and more efficiently than just a regular mask. So usually ventilator is used for more severe cases. So that's one of the supportive care that we try to provide to patients so that the body can recover, past the infection, past the inflammation, which we'll talk about a little bit later, so that, once if they improve and, we could see whether we can remove this ventilator from the patient. And the third modality that we tend to talk about as well is that, we found that for the patient with COVID-19, they tend to form these blood clots in their blood vessels. more often than patients without. And, you know, I'm talking about, you know, in our body, we have the arterial system, right? You know, that's the vessels. And most of the time, bring blood from the heart out to the body. And then, you know, the blood return is the venous system. So, you know, we tend to see that these COVID-19 patients have more clots form in both vessels, the veins or the arteries, more than other patients. So in patients who do not have any contraindication to be on a blood thinner, you know, which is also known as anticoagulant. So anticoagulant is a blood thinner. So we place actually these patients on a blood thinner, the doses depending on how severe they are or what kind of evidence that we have. So we do that quite often. And actually, you know, we do that quite often with patients who are actually hospitalized anyways. But, you know, these patients tend to clot a little bit easier than other patients. So that's something that we also use as a supportive care modality. So, you know, besides the you know, flipping the patient over on the belly, using the ventilator if we need to, put the patient on blood thinners such as anticoagulants, there are a few medications and other treatment that, again, you know, all of us have heard in the news over the last few months. And the first medication that on this slide is remdesivir. So remdesivir is an antiviral, and you know, it has been used before for other viruses. I think was that Ebola, Dr. Reyes? Was that studied back then when the Ebola came? So it was studied by a pharmaceutical company, and it seems that we do the testing, and it shows that it may help. Actually, you know, basically shorten the amount of hospitalization and, you know, shorten and make the patient actually recover faster if in the appropriate patient. So remdesivir was you know, had this, you know, we see it all the time as well. It's an emergency use authorization, an EUA from the FDA, because it doesn't go through the whole process of drug approval like other drugs. So because of the study that showed that, you know, the preliminary data showed that the drug can reduce recovery time in patients with COVID-19. So it had this EUA from the FDA. So we do use remdesivir in the appropriate patients. And the second medication that you see is dexamethasone. So dexamethasone is actually a steroid. And, you know, steroid is something that fights inflammation. And again, you know, the NIH also suggests that, you know, we can use dexamethasone in the appropriate patient. And usually those are the patients who will need oxygen. So I just want to go back a little bit and talk about, you know, and I would invite Dr. Reyes to jump in here if there's anything that you can add on to my spiel here. So, you know, when the patient just gets infected with the virus, right? So, you know, the first phase, the first few days, and we talk about all these symptoms, fever, body aches, you know, they can have these gastrointestinal symptoms. And this is when, usually in the beginning, this is when the viruses replicate. They replicate in our body, right? So usually we call that as a viremic phase. So this is when the virus are like abundant in the body. And when the viruses do that, when the virus does that, our body actually responds. You know, our body immune response kind of like reacts to what the viruses do. So we have a second phase of the infection we call the inflammation phase. So usually, again, things may change in the future, right? But right now, we tend to look at the whole, you know, infectious spectrum. Is you got the viremic phase where the virus kind of like working hard, and then the body reacts, and we get the inflammation phase. So by using medications differently for, you know, these phases, we try to help patients to sort of like, you know, shorten their hospitalization if they need to. So dexamethasone has been shown that if the patient requires oxygen, whether it's just some nasal cannula on their nose or, you know, they end up in a ventilator, actually dexamethasone really showed to help those patients. And, you know, interestingly, in the group of patients in that particular study who did not need oxygen, actually dexamethasone kind of like did the reverse. Actually, it actually hurt those patients a little bit. So we really reserve dexamethasone in patients who need oxygen supplementation. The third thing there is convalescent plasma. Again, you know, we've heard about convalescent plasma, and recently it did receive the emergency use authorization from the FDA. And again, you know, these are plasma from recovered patients who had the infection, and, you know, they're recovered, they're able to, you know, donate their blood, and, you know, it was working in ways that, you know, we obtained the antibodies from these recovered patients' plasma, and we transfuse into the patients who had COVID-19. And it has been used quite on a lot of patients in the U.S. It's been known to be, it's been shown to be quite safe. But in terms of the efficacy, the jury is not out there yet. But it's used relatively frequently with our patient with COVID-19. And then the last but not least on there is the infamous hydroxychloroquine, okay, or chloroquine. It is a very old drug. It's been out there. It's used a lot for patients with rheumatoid arthritis or malaria and lupus. And it's probably the most talked about medications in the press, depending on which aisle you're on. However, the FDA has since then revoked the emergency use authorization for this particular drug due to a lot of studies that came out and showed that it was not really effective, and actually it can cause a lot of harm as well because of its side effects, especially the cardiac side effects. So right now, it can only be used in some clinical trial setting. Dr. Reyes and I, just like I mentioned earlier, we had managed a lot of patients with COVID-19, and this is one of those medications that we are not using currently. And also the first three are the ones that we actually use quite often in the appropriate patients. We have to look at the timing of their presentation, because certain medication like remdesivir, for example, the patient has had symptoms for like 2 weeks, 3 weeks. It's past that viremic phase that we talked about, so it may not work as well. The dexamethasone wouldn't work with a patient who doesn't require oxygen, and then convalescent plasma again. So we have to really pick and choose which patient we provide these therapy. We have guidelines. It's not like we flip a coin and choose. There's guidelines. We look at the research studies that put these modalities on for emergency use authorization. So we evaluate every patient individually to see which therapy would help them. Again, the top three are the ones that we use quite often in the hospital. Okay, so the next completely different is we talk about face covering. Again, very hot topic as well. Depending on what you read, what you hear, it's a good thing to do. It's a great thing to do, but just remember, it's not a substitute for physical distancing, washing our hands, and also staying home when we're sick. Quarantining ourselves. So put on face covering. Wash our hands obviously before we put on the face covering. Make sure that both our nose and mouth is covered, and the bottom one is usually underneath our chin. And taking off face covering, touch on the side, the loops or the tie that's in the back, and fold the outside corners of face covering together. And try not, when we remove these face covering, try not to touch, the mucous membranes like our eyes, our nose, or our mouth. And then obviously after we remove that, wash our hands immediately. And a lot of us use the washcloth because it's a little bit more comfortable. They should be washed daily, and then with detergent and hot water, and dry on hot cycle. All right, so some examples of the face covering that we see, and we start to see that people get very, very, very creative with these face covering. Political messages, advertisement. Just red lips on the face covering. So these are the ones that we tend to use the most. N95 respirators, N95 masks. Again, this is what we hear quite a lot. It's tight fitting. And when we use the N95, we usually have it fitted. We want to make sure that that particular N95 fits our face, because there's different types, different sizes. You can have an N95, but it doesn't fit your face, and it really defeats the purpose of what the mask can do. So it reduces the person who wears it exposure to small particle aerosol as well as large droplets. So it protects the person who wears it quite a bit. It's 95% of all the materials. And usually it's used more for healthcare workers, and it's not recommended for the general public. On the other hand, surgical mask, it's fluid resistant, it's disposable, it is kind of loose, a little bit easier to use. And again, it protects actually the person who wears it against large droplets. And it also protects others from the person who wears it, if they happen to cough up anything. So surgical masks are probably used the most often. And just as I mentioned earlier, cloth face coverings, bright materials, cotton, silk, linen, should be washed frequently. It reduces the release of these infectious particles into the air. And you know, if I have something, it will prevent other people, you know, me transmitting all these infectious particles to others. And face shield, again, it's not recommended as a substitute for mask, and it's usually, you know, it protects more of the eye. And you know, a lot of times in the hospital, I mean, that's what we do. We put on whichever mask and on a certain setting that we go into, and we also use the face shield as well. So these are the face covering. We talk about N95, surgical mask, cloth face covering, and then face shields. Soap and hand washing, I mean, we can't stress enough how important just a simple hand washing is. You know, just any day, you know, on our daily life, but especially right now, you know, just remember, wash our hands with soap, water for at least 20 seconds. And if soap and water are not available, then try to use this alcohol-based hand sanitizer of at least 60% alcohol. And, you know, there's a nice diagram there how soap works. So we lather our hands with soap for about 20 seconds, and it, you know, kind of like disrupts this membrane around the virus, and it destroys the virus and other, you know, pathogens along the way. And then these fragments, you know, when we wash our hand, it just get drained, get down in the drain. So again, wash our hands 20 seconds with soap and water or alcohol-based sanitizer of at least 60% alcohol. Face covering, hand washing, social distancing. You know, those are, again, you know, we can't stress enough how important that is in the community, especially now that we're quote unquote opening up a little bit. So key takeaways. So that was a lot of information between mostly Dr. Reyes. You know, like I said, my portion was much simpler. Anyhow, these are the key takeaways. So I'm going to hand back to Dr. Reyes, who addressed the first 3 bullet points there, and I'll tackle the very difficult last 2. Go ahead, Dr. Reyes.
Okay, thanks, Dr. Lake. So again, in terms of the testing, 2 big categories: screening versus diagnostic tests. So when somebody comes in or tells you that they have some symptoms, you need to send them for a diagnostic test, and that's usually molecular PCR or antigen test. Molecular PCR are ideal, that's preferred. And again, remember, antigen test, if that's what you have, or that's a test that's available, then it's good but not great. You want to confirm it with a molecular test. And then the screening or antibody test or serology test, that's not useful for diagnosing acute infection. Next bullet point, quarantine versus isolation. Again, mainly it's isolation now, because again, we do have the capability of testing people. So isolation, we tell people to stay in a separate room, separate bathroom from, you know, up to 10 days after their symptoms started. And then lastly, in terms of my bullet points, contact tracing, the healthcare agency will mainly take control of that, but it's still wise to tell the patient to help the contact tracers by notifying their contacts themselves.
And in regards to treatment and vaccine, as you know, we talked earlier, I mean, unfortunately right now, there's no specific antiviral for the SARS-CoV-2. Supportive care is what we do every day now. And certainly, you know, a few modalities that we talked about, remdesivir, dexamethasone, as well as convalescent plasma that are used in appropriate patients. And we're still waiting for those quote unquote safe and effective vaccine. And they're being tested on phase 3. Again, face covering, social distancing, and hand washing. And, you know, whether you believe it or not, but, you know, I think the director of the CDC did say that, you know, just with the covering, social distancing, we can really get this pandemic under control. So just be, you know, be thoughtful for others. And, you know, hopefully by working together one way or another, each of us has a different role. And I think that once we start working together and, you know, believe in the science, I think we'll defeat this thing sooner than later. And I think that is our last slide. And again, you know, on behalf of Dr. Reyes and I, and also we would like to thank again the forum for us to have this kind of time to talk to all of you, and hopefully you walk away with a lot of useful information and you transmit it forward to the community. And I will let Dr. Reyes have a few last words before we'll take some questions and take some questions. Okay, Dr. Reyes.
Yeah, I just also want to reiterate my appreciation for the invitation, and also my appreciation for what you guys do for our respective communities.
Okay, we'll get back to you, Becky and Jung, to see how we're going to proceed with the Q&A session.
Thank you so much, Dr. Huang and Dr. Reyes, for the training today. Right now, everyone, if you have any questions, you will be able to unmute yourself and ask your question with the doctors.
Hi,
I also have one question in the chat box. Okay, go ahead, Ellen.
Yes, sorry, Becky, I interrupt you. So we got several questions from our community also. So this is Eileen from ASCSC. So one question is, for example, the people who come back from a quad or from outside or from the airport, do they need to quarantine themselves?
So I believe the question is travelers from another country, do they need to quarantine themselves?
Or even from outside states, I would say, but also there's some people like from outside country, yeah.
You know, I'm not 100% on this, and I'm not sure Dr. Lay would know, but because our community transmission spread is so high, I do not believe we are requiring quarantine and any travelers from outside the region. So, you know, as I think we all heard that, you know, places where there was low community transmission, like Hawaii, up until recently, or up until a few weeks from now, they are requiring quarantine. I do not believe that's the case in Southern California. I'm not 100% on that, but I think that's the case.
Okay, thank you. And also, there's a question about the 10 days after the symptoms appears. So does that mean like on the 11th day will be safe for the person who choose to isolation to just go out and don't need to worry about?
Yes. So that is, in general, that's correct. So previously, before we had more data, I mean, more information, especially because, again, the molecular test can be positive for weeks and weeks. We were not sure what that meant, and we thought maybe they were still contagious weeks and weeks later. So, but since then, we do have pretty good information from researchers that, again, we're pretty firm in the belief that people are no longer shedding, you're now no longer contagious. You're no longer shedding infectious viable virus after 10 days from the start of somebody's symptoms. And again, that's probably 98% of the cases. Now, in like somebody that's a lot sicker, you know, somebody in the ICU, for like some of these patients we treat, Dr. Lay and I treat for a few months. So they're sicker, and maybe they're older or their immune system is weaker, then they could potentially be contagious for longer than 10 days. But even then, there's been nobody that they found to transmit in contagious virus after 20 days. But again, for the most part, for most, you know, most people that are, you know, healthy enough to not be in the hospital or even admitted to the hospital for a few days, but did not get all that sick, 10 days is usually the time frame. 10 days from the start of symptoms is when we can feel comfortable to say that they do not need to stay in isolation. Again, we stress, you don't act like you're Superman or Superwoman at that point, because, you know, we still want you to do all the things that Dr. Lay talked about: social distancing, hand washing, face masks. So you know, the graduating from 10 days doesn't mean, you know, you can just be completely lax about transmission.
Okay, thank you.
Thank you, Doctor. There's a question in the chat box asking that if suspect that a person has been in close proximity with an infected person, how long should that person wait to get tested?
I'll take this one. I'll go ahead and take this one. So once again, when you get exposed to somebody, usually the average incubation is about 5 days. And so remember, you don't really start to shed virus until about 2 days before you develop symptoms. So 5 days forward, 2 days backward, that means about 3 days, right? 3 days usually after exposure is when you should get tested, not sooner than that, because most likely it's going to be negative before, so again, at least wait 3 days after the exposure to the positive patient. Did that answer the question?
Yeah, thank you, doctor. And we also have another question from Okabika. Is that if any sign and symptom where the patient is not getting enough oxygen, we would ask the patient to go to the hospital, or if the patient is only have the primary symptom like coughing, fever, or sneezing, they probably can stay home. So what sign of symptom that we should tell the patient that they go to the hospital?
I'll take this one. It's a great question. So usually what we advise patient is the majority of the patients who show up in the hospital is because they're short of breath. Okay, I mean you feel the short of breath. They breathe faster, and some people actually have. I mean nowadays this thing called a pulse oximeter. I mean it's relatively inexpensive now, so a lot of people actually have it at home. And the level that we would like to see is usually greater than 92 or 94% on these folks with COVID-19. So we tell them if they happen to have this pulse oximeter at home, obviously if it's less than 90%, we recommend them to seek medical attention. But a lot of times the patients don't have that particular device, and we just tell them that if they just feel short of breath, just be on the cautious side. Go get evaluated. If your oxygen level is not low, then that's fine. But we don't want them to stay at home and just kind of pretend like Dr. Marvin Reyes said, Superman or is it Superwoman or is it Wonder Woman? Okay, I'm sorry. So just those are the most important symptoms that we tell patients to seek because they can be life-threatening. And some patients do show up with gastrointestinal symptoms. They throw up so much, they're so tired, they have a lot of diarrhea, they become so dehydrated. So those are the patients who also usually show up. But the majority of the patients who show up in the ER we see is actually because they're short of breath and their oxygen level is low. So just tell them, err on the cautious side. Just seek medical therapy because COVID-19 can be quite devastating for a lot of the folks with comorbidities. I hope that kind of answered it.
Yeah, thank you, Dr. Ray. And another question for Dr. Reyes. If the antigen test is less sensitive than the PCR test, then why is it that providers would even recommend the antigen test? Is it something that a patient has to particularly request, or is understood that a PCR test will be provided?
So I think it just depends on what's available at that particular testing site or doctor's office. So even though I did say that the antigen test is slightly less sensitive, it's not like it's terrible. It's still reasonably good. So I the flu for influenza, the flu antigen test is a lot less sensitive than the PCR test, like 40-50% at best for the antigen flu test, compared to like 90% for the PCR for flu. It's not the case for COVID, at least from what the published data that we have for these antigen tests. The sensitivity is still close to 90%, if not over 90%. It's not that bad. So you know, it's still a reasonable test. If that's what's available, I mean, it's cheaper, I think, in general. It's faster. The test results are faster. So I think that might be a reason why that's more available in some places. And it's still pretty good. But, you know, like we alluded to earlier on, if the patient, you know, has more of the signs and symptoms, and the antigen test is negative, that's when we would, you know, recommend that they get don't stop at that negative antigen test. I don't necessarily know that a patient could you know, ask for I mean, I suppose, you know, if they go to a place where they get tested, they should find out, is this an antigen test or a PCR test, just to kind of educate themselves. But I don't think necessarily we have to tell them that you have to request the PCR test. I mean, sometimes it's just not available. And again, you know, antigen test is better than nothing, but it's just, you know, again, if they get the negative result, you just have it in the back of their mind, that the back of their head, that it's possible that it's a false negative.
And just to add a little context, you know, we do use the antigen test in our hospital, and, you know, it's usually in the ER, and our ER doctors tend to use the antigen test in the patients that they think there's the good likelihood of infection, you know. And so those patients, just like Dr. Reyes said, if it's positive with the antigen, you know, that's it, you know, we're done. The patient has COVID-19. The antigen testing for the hospital per se are a lot more available. You know, but then again, if you have the patient have all of these symptoms who have the negative antigen test, we always automatically follow up with the PCR. And you know, hospital setting is a little bit different than the community setting. And again, we you know, both Dr. Reyes and I do not do outpatient testing, so we don't know what the availability of the antigen testing in the community. And, you know, with the folks that we work with who do test patients for COVID-19, usually it's a PCR test. But yeah, I think it's a good question to ask what test they're getting, you know, because there's different certain levels of sensitivity and specificity. You know. But if you can get a PCR test, I think that's again, like Dr. Reyes said, is the gold standard. But again, depending on the area, certain areas, the PCR tests are very difficult to come by, or it takes so long. So antigen test is better than nothing.
Thank you. And the next question is, if a person got COVID and doesn't develop antibody, can that person get the COVID again?
So, you know, right now, again, there is a few cases, I think, worldwide we've heard that there's possible reinfection of COVID. I mean, the answer is we don't know. Is there a high likelihood? Probably not. But still, at this time, you know, we still don't know how long the patient is immune for, right? Is it 3 months? Is it 6 months? Is it 9 months? Is it a year? So we don't know. And just like Dr. Reyes said, you know, once you're fortunate enough to recover from COVID-19, don't behave like Superman or Wonder Woman. You know, still face covering, still protect yourself and protect others. So the answer is that we don't know. It's probably not high. It's not like somebody who got infected for example, in July, and, you know, now gets reinfected. It's a possibility, yes. The likelihood, probably not. And I think that I just want to add in a little bit more. Is that I think the CDC just came out yesterday, Dr. Reyes. You know, I just heard this morning, again, you know, the CDC guideline changes on a daily basis depending on who influences them. But I think they say that up to 90 days, you know, the PCR test or even antigen test can be positive in those patients. So that's just something to think of. But yes, there's a possibility you can get reinfected. It's not likely, but, you know, with infection, I mean, this is still a brand new novel virus, so we still have a lot to learn from it. So just still continue to be careful. Don't go crazy after you recovered from COVID-19. Just be thankful.
Thank you. Yes. The next question is that there's some, you know, tests that only take a few hours to get the result. Could you please talk a little bit more about those tests and how effective they are?
Yeah, so it depends. That's the bottom line. So again, most of these, the rapid tests are antigen tests, but some rapid tests are also molecular tests. So for the most part, those are still quite accurate. And again, PCR tests are the best, highest sensitivity. Antigen tests, slightly less sensitive, but still quite good, still quite accurate. And bottom line, if somebody, sounds like they have it, feels like they have it, do not stop at a negative test necessarily. And that's usually something that you would probably refer them to see their clinician, their physician, to guide them what to do. But I would still encourage them to, act like they have it, even if they have a negative test. Stay in isolation and do all those things. But in general, they are still accurate. Antigen tests and PCR tests.
And I just want to add a little bit to that. And also it depends on the system that, that either the hospital has or a clinic has. Most of the antigen testing, like Dr. Marvin Reyes said, is very fast. Most of the antigen testing are super fast. But in terms of the PCR, I think that's one system by Abbott. We all heard about it, the Abbott ID. So they're pretty fast as compared to the other system of PCR. It may take like a few hours. The Abbott system takes pretty I think 15 minutes to 30 minutes. And then again, there's a certain sensitivity and specificity that comes with it. But really depends on the system in regards to the PCR. If you take a few hours to a few days or a few minutes. But the antigen overall, the antigen testing are usually pretty fast.
Thank you, doctor. The next question is that for the antigen test that are administered by the patient and not the provider, which is like swab your own nose, have any studies show that the self-testing to be less accurate than you go to the provider and get tested at the provider? And also it will lead a little into the next question, like for children who can't take the nose swab techniques, can they take the blood test instead? And between those two, the accuracy and sensitivity, could you please explain a little bit more about that?
I can take the first question. That's a good question. So these self-administered tests. So in the big, earlier on, a few months ago, it was felt that the site of the collection, mattered in terms of how accurate the test is, how sensitive the test is. So, we were thinking that the deep nasopharyngeal specimen, which cannot be self-administered because it really a healthcare worker has to pretty much jam the swab deep in, and the patient themselves cannot do that. Those were felt to be more accurate than the ones that you just swabbed out, the slightly inside the nostril or the throat. But subsequent papers have shown that some of even the nasal ones, the ones that are not that deep, or even one of the ones, the throat ones, may come close to the sensitivity of the deep nasopharyngeal swab. And I think, in fact, regarding some of these like saliva tests, the home saliva test kits, I think I don't know if it was JAMA or New England Journal published an article a few weeks ago or a month or so ago that said that the self-collected, this was a nasal swab, self-collected nasal swab, not a saliva test. But anyway, they found that the self-collected nasal specimens had sensitivity that came close to a nasopharyngeal swab collected by a healthcare worker. So again, the bottom line is, it depends on the kit. I don't know all the performance data for each particular test, but in general, it's felt that even now at least, even the self-administered non-deep swabs might be approach the sensitivity of a healthcare provider administered swab. But still, the gold standard still is healthcare provider administered deep nasopharyngeal specimen. And
What
then
was
the second?
Yeah, what was the second question? Can you repeat it?
The second question is for the children who can't take the nose swab technique test. Can they get a blood test instead?
So, for the blood test, the only thing that we can test for is the antibodies. So it doesn't tell us, the acute infection. So, I mean, just to answer that questions. And again, it's a good question. I don't know whether Dr. Reyes knows the answer to how we test kids, because, both of us actually don't see kids at all, and I just don't, it's a great questions. I don't know. I mean, in terms of, luckily we all know that the kids don't get infected, knock on wood, as much as the adults. So I really don't know how to test on the kids. But, just to answer that portion of it, there's no blood test that can check for acute infection. Yeah, the blood test only checks for antibodies, just like Dr. Reyes mentioned earlier in the talk. You know anything else about how to test kids, Dr. Reyes? Is it still probably just a swab?
I actually don't. But I think you're right. I think it has to be a respiratory tract specimen.
But no blood tests, unfortunately, for either adults or kids to really detect acute infection.
Great. Does anyone else have questions? We're coming down to a few minutes before the promised time. So does anyone else have any questions? Great. Well, I wanted to take the opportunity and thank Dr. Marvin Reyes and Dr. Huang Lei for being our champion in educating us about various types of testing, and also just to reiterate the importance of prevention, or the social distancing, the hand washings, and the face we call it mask, but face coverings anytime would be great. So we certainly appreciate your time very much, and I just wanted to reiterate to everyone who is in attendance today. First, thank you so much for joining us and learning more about COVID-19. It is impacting each community very differently, and so as API COVID-19 response team, we certainly are here for you. If you have any questions, please don't hesitate to reach out to any one of us. Beside BACF, we have OCAPICA, KCS, Asian American Senior Citizen Service Center. That's short for AASCSC. So if you see that, please, that's what it stands for. In addition to that, it's Hope Community Service, and then Pacific Islander Health Partnership, or PIP, SAN, South Asian Network, and Southland Integrated Services. KCS and Southland are two of our community-based organizations who will be providing testing. So call us and we will navigate you to the proper places for testing. And then in addition to that, we have the Cambodian family, B-Rock. So we're all here for you. If you have any question about what is COVID-19, what is the latest updates about COVID-19, where to go testing, where to get more information about testing and what those testings are, please reach out to any one of us. We're here to support our communities. And so definitely check out our website, bacf.org. So thank you so much for being here. We certainly appreciate your time, and stay tuned and stay connected. And here's for the community. Thank you.